Hi everyone, good afternoon. Hope you all are doing well. Welcome to our second to last session of 2025 for our San Joaquin Stanislaus Collaborative. Thank you all for joining us today. Just a few housekeeping reminders per usual. We are recording this session and we will send out the recording link in our follow-up outreach email that we usually send the week following the session. And then for today's icebreaker question, since we are fastly approaching the holidays, and I know I associate good food with the holidays, so wanted to ask folks to share what your favorite holiday dish is, or maybe, what is something that you think of in terms of food around this time of year. And hopefully that'll give us some good inspiration to maybe try something new. I know I'm always looking for new recipes. And as always, just encourage you all to use the chat function as you have questions or unmute. We really want this to be engaging and make sure that we're really addressing any questions or feedback that you all have for us so we can make sure we address that. And then for today's agenda, after our welcome and level setting, we will be spending some time kind of walking through compliance requirements, specifically focusing on transitional rent and justice involved, as well as general compliance requirements. Building off of what we kind of talked about in September when we did a walkthrough of PAVE, we are bringing Carrie in from Tracy Community Connections just to share some of their tips and guidance on applying for PAVE since they recently went through that process. And then we also have a spotlight through Central Valley Low Income Housing, who is the lead agency for HMIS in San Joaquin County. So they'll be providing a refresher on HMIS as well as how you can get set up for obtaining a license. And then we will hold some time towards the end for Q&A in this section. So really encourage you all, if you have questions, to please make sure you address those there. And then we'll move on to some cross-sector policy and regional updates. So per usual, we'll get to hear from each of the MCPs for any updates that they have. And then I will be sharing some CalAIM related resources and announcements that you all should keep on your radar. And afterwards, we are doing this session a little bit different as we're combining office hours instead of having it on a separate day based on your feedback. So we will be touching on financial sustainability and talking a little bit more about how organizations can manage and assess risk. So for today's objectives, by the end of the session, participants will be able to understand key contracting and compliance requirements for transitional rent and justice involved services and learn best practices for completing enrollment through with DHCS through the PAVE portal. You'll also gain a better understanding of the Homeless Management Information System, also known as HMIS, in the context of transitional rent, since that is a requirement, including its key benefits and the steps required to obtain a license, and then receive regional MCP updates and CalAIM related announcements. So with that, I will pass it to Rebecca to lead us through our next section on compliance requirements.
Thanks, Navneet. And you got my mouth salivating about pumpkin pie, thinking about fall foods. I will admit I've already partook many weeks ago in pumpkin pie, so I'm already well into the fall season. And I already saw someone talk about pumpkin pie in there. So thanks a lot for that. Hopefully you guys are not too deep in your post lunch lull. So hopefully I can wake you up with some very exciting topics on PAVE and HMIS today. Next slide, Navneet, please. Thank you. So we're going to jump into some compliance related items today. It is a continuation, as Navneet mentioned, on a prior conversation that we had about PAVE. And we're lucky to have Carrie joining us today to share the experience that her organization had to successfully make their way through PAVE. In addition, I'm going to cover a newer topic that I'm actually not sure if you guys have covered yet in the CPI, but we're going to move into more of an systems and infrastructure discussion, particularly pertaining to transitional rent and HMIS system. So we're lucky to have John to join us to share more details on that today as I facilitate this section. Next slide, please. All right, so I actually had this slide in a prior presentation, but I want to go through it again because I know that PAVE, which is the Provider Application and Validation for Enrollment portal, is a bit confusing to folks and if it's even relevant to your organization. So we're going to go through that again today. And this is really all about a pathway for enrolling as a Medi-Cal provider with the state, with the Department of Healthcare Services. There may be different reasons why you would do that. If you are a justice-involved ECM provider, you are required to do this. And that is because if you want to get paid for services that you're providing to individuals while they're still incarcerated, then you're going to actually be billing the state and not the managed care plans as you typically do in the post-release period. You're going to be billing the state pre-release so that you can get reimbursed for those services. So there are different reasons why folks need to enroll and pay. We're going to talk about that today. And this may be done in conjunction with your managed care plan contract. So even though you have contracts with managed care and you may be operating solely as a managed care plan provider, you may still need to enroll through the state system, okay? So just note that. And then one thing the PAVE portal is not is a billing system. A lot of folks get confused with that and they think that they're going to enroll as a Medi-Cal provider through PAVE and they're also going to bill the state through PAVE, but there's actually a whole separate aspect that goes into the billing. And once you're in PAVE, you'll get access to the Medi-Cal provider portal. So there's like other systems and things to do, but PAVE itself is specifically for the pathway for Medi-Cal providers to enroll with the state. Okay, so that is the sole purpose of it. Next slide, please. Okay, so I already mentioned, and we talked about previously in a prior presentation, that the justice-involved ECM providers or ECM providers serving individuals who are transitioning from incarceration are required to enroll through PAVE, and it is the first step to be able to set up billing pathways for services provided in the pre-release period under fee-for-service Medi-Cal. I know that's a lot. For those of you who are involved in this, you should already know this information. So hopefully this is not new to you. But what I think is a little bit newer is the concept of enrolling through PAVE as a community supports provider, okay? And this is going to be relevant for our discussion about transitional rent that we're going to continue on taking up in a moment. And this is actually relevant for other community supports providers as well. So what you need to know is that if there is existing a state level pathway to enroll directly with the state, regardless of if you have a managed care plan, if you're just solely operating under a managed care plan contract, then you will need to enroll as a CS provider with the state through PAVE, okay? So we'll talk a little bit about what that might look like for transitional rent providers. But for example, community-based organizations are an entity that didn't used to have a pathway to enroll with the state through PAVE. And now that pathway has been created. So any CBO providers that are serving as community supports providers would be expected to enroll through PAVE, okay? The other one I just want to mention, for those of you who are providing multiple types of CalAIM services, is community health workers. So this is another one where, similar to the JIECM providers, there are pathways to provide services both under managed care plan contracts as well as under fee-for-service Medi-Cal. And so there is an expectation if you are providing CHW services as a Medi-Cal benefit, then you should be, if you have that pathway, you should be enrolling as a provider directly with the state through PAVE as well. Next slide, please. Okay, we had this slide previously, but I want to bring it forward because I know that we have a lot of community-based organizations on the call and as part of the CPI. So this is a bunch of information. You guys are going to get the slides, and there's links in here and all this stuff. But this is really meant to be resources for CBOs in particular to support your enrollment under PAVE or through PAVE, the state portal that I've been talking about. So you can take a look at this information on your own time. I want to call out two things in particular. One is that as a CBO, you must be a nonprofit organization, okay? That is the only way you will be able to enroll through PAVE. So just note that. The other is that before you even begin your PAVE enrollment, you need to get what's called a National Provider Identifier, or an NPI number that is obtained at the federal level. So you'll need to go and get that. It's a fairly straightforward process. You'll need to get a type 2 for your organization NPI number, and then you'll be taking that number, and that's what you're going to use to proceed with your PAVE enrollment. So those are two things that you need to be aware of before you even begin the process of enrolling through PAVE. So just want to call those out in particular and encourage you guys to take a look at these resources because they do provide helpful screenshots and checklists and step-by-step information to work your way through the PAVE enrollment. Next slide. And thanks, Melissa, for sharing the links in the chat. I'll call that out. Okay. So with that, I'm going to just pause for a minute here. I'm going to invite Carrie to jump in on the conversation from Tracy Community Connection Center. They have successfully worked their way through PAVE, and so she's going to share with you guys some of her PAVE application tips and lessons learned. So Carrie, are you still with us?
I'm right here. Yes, thank you so much. Um, so I had put a few tips in there, but I have a few other things to add. Really simply, for whatever reason, Safari seemed to work better for me than Chrome. I don't know why, but so just a little tip there. Um, oh, I should start by saying that we are a community supports services provider. We do the housing trio, and then we're going to be also doing transitional rent in Stanislaus County. Um, the other thing that would be helpful is make sure that you have one person who is the provider administrator because a user cannot submit all of the documents. So you want to make sure that you are enrolled, whoever's completing this, as the administrator, so you can submit things and that you start out as a new enrollment if it's brand new, not a revalidation, and that you start out as an organization, not an individual provider. And then you're going to have to submit a bunch of stuff, like she mentioned, have an NPI, your 501(c)(3) paperwork, your proof of liability insurance, a board roster, and you will have to provide driver's license numbers, social security numbers, and birth dates for you as the admin, and then any board members. I did experience some pushback from my board on that, so be prepared to figure out a way to carefully uh, get those from people and then destroy that information however they feel comfortable. But I did have to do that. I had to submit an actual copy of my driver's license as the administrator. Um, and then as you're submitting stuff, it will say red flag if something's not right. So it'll kind of stop you. You're able to go in there and see what the issue is. I did also have to get my entire application notarized. So be prepared for that. Um, and then once you submit it, they will come back with corrections, which I was able to easily correct the little things. It wasn't a big deal. It wasn't like, oh no, I have to redo the whole thing. They just asked for additional things. And just really carefully read it. It says you can't leave any lines blank. So I just wrote NA on, I want to say like dozens of lines because it really wasn't applicable, but it did say not to skip a single line. So I just wrote NA all over and over and over and over again just to make sure that I didn't skip a line. Um, I think those are all of my tips. I don't know if anybody has any questions or if I will even be able to answer them, but those were some things that were helpful for me when I did mine.
Carrie, I'll ask you a quick one, and I will
Yeah.
take some questions now and at the end too, if you guys want to mull this over, when we do the HMIS as well. But I want to ask you, Carrie, when you were talking about doing revisions, how did you communicate with the state? Was it like through their portal? Was
Mhm.
it emails? Like, how can folks expect to hear and get communications from the system or from the state?
So the portal would send me an email saying you have a message, and then you would go log into the portal. But I was surprised at how quick they responded. They were helpful, they were friendly. So yeah, it was mostly email, but you did have to log back into your portal to access those messages. And again, for whatever reason, I couldn't get in Chrome. Safari worked better. So just a little note there.
That's interesting. When does that ever
Yeah.
happen? I'm not sure. I
I
can't.
don't know. And maybe that was just my computer. Who knows? But I got
Um,
very frustrated at first when I was on Chrome. I was like, why is this not working? And then when
that
I went to support, it was fine.
That's a huge tip. So really appreciate you sharing that and all your other tips. If you could stay on, Carrie, I think we're going to take questions at the end because I understand that John, who's going to do a short presentation on HMIS in a minute, needs to hop shortly. So let's go to the
Oh,
next
sure.
slide. But Carrie, yeah, if you could stay on and we'll take questions. So folks, start putting your questions in the chat and we'll take those in just a few minutes. Um, Before I get to John, I just want to I want to sort of wrap up our PAVE conversation and move us towards transitional rent, and then we'll talk about HMIS as well. So when it comes to transitional rent providers, as I mentioned earlier, if you're a community supports provider, which transitional rent is, it's the newest community support, then you will need to enroll through PAVE if there is a pathway for your organization to do so. So CBOs, as we talked about, have a pathway now. One example where there is no pathway are housing agencies. So just be aware of this. It will depend on what type of organization you are, whether or not you're going to enroll through PAVE as a transitional rent provider in particular. Okay. So want to call attention to that. Now, let me move over the conversation into HMIS, the Housing Management Information System. This is a system that will gather information about individuals who are experiencing homelessness in your community. And it's a way to support coordination of services for these individuals, okay? Now, the expectation from the state is that transitional rent, individuals receiving transitional rent will need to be included in HMIS beginning in January of 27. Who exactly is going to do that can be these different providers that I've listed on the bottom right of the screen. And I think what is going to happen at the end of the day is probably it's going to be based on the managed care plans and how they decide to implement this. So as a transitional rent provider, you may be asked to enter information into HMIS. So just be prepared for that. And that's why we want to give you some information about what the system is so that you're informed and you know what you need to do, or at least where to begin moving forward. So we can go to the next slide. I'm going to invite John. John is from the Central Valley Low Income Housing, and they're the lead agency, as far as I understand. John, you can correct me if I'm wrong, but you're the lead agency for HMIS in San Joaquin County. So we're very lucky to have you to share a little bit more about this system, and so folks can get a sneak peek in what this looks like and what they might be expected to do in the future. So I'll turn it over to you, John.
Great. Thank you, Rebecca. Appreciate the chance to be here. Can everyone hear me okay?
Yes.
Great. All right. So we're going to do a really quick overview. I don't have a sneak peek into what the system looks like if you logged in, but we do extensive training. So anyone who is not a participant in the system, we can give you that look in, and it's a really user-friendly, easy to operate system. So a little background for those who may not know what the Homeless Management Information System is. It's a system for collecting demographic data, monitoring performance, and doing reporting on outcomes for projects that focus specifically on homelessness assistance, right? So your outreach, emergency shelter, transitional housing, rapid rehousing, rent support, permanent housing, rent support, all of those types of programs are in many cases required to report through the HMIS. It collects data throughout a continuum of care. Continuums of care have different boundaries specific to different communities in San Joaquin County. Our continuum of care is the San Joaquin County border. So if you're doing stuff in San Joaquin County, you need to have access to the San Joaquin County continuum of care HMIS. If you're doing something in Stanislaus, you need access to the Stanislaus HMIS. If you're doing services in both, you're going to need access to both, and you're going to need to be able to determine, did we provide a service to a person in San Joaquin County or Stanislaus County? So you only get one HMIS per continuum of care. You only have one HMIS lead per continuum of care. Again, Rebecca, you were completely accurate. We're the HMIS lead for San Joaquin County. I put our basic contact info into the chat. So if anyone wants to get in touch with us or learn more about it, email those emails. One of those is mine. Visit our website, and there's a lot more information there. We use Clarity Human Services. That's the logo that's out there. It's the #1 HMIS software in California. So it's not just used in San Joaquin County. The software is used actually across the nation and has a huge team for technical support behind it. So you can be sure if you're entering information to this, it's always up to date with federal data standards, reporting standards, et cetera. So it's a really great piece of software, really easy to use. Can we go to the next slide, please? Thank you. So the pictures you see there are a couple of reports that are pulled out directly from the system. Again, you do not need to be a data expert to be able to do these reports. You essentially put in like what program you want to report from, the time period, and some other real basic pieces of information that are all on basically drop-down menus. And it produces dozens and dozens of reports on your projects that you're inputting data for into the HMIS. So not only is it good for an agency to keep track of their data, but it's critical to understanding our overall homeless response system. But again, it goes down to agency by agency, program by program, and service by service. So you can track data to the extent that you're putting data in. It's cloud-based, so it works anywhere you've got internet service. You don't need to download anything. You don't even need to download an app. Just put the URL in and download a shortcut to your smartphone, your tablet, or your computer. It's real-time data entry, real-time reporting. It allows you to tag the geolocation of client contact points. So if you're doing outreach, the location feature is really, really helpful. You can start kind of figuring out where your clients are. Um, Another handy feature is this shares client program and service history with all the other participating agencies. And that's part of the release of information that people sign when you put your info in here. But that means if Central Valley Housing has contacted this person and has provided them housing support, they can see that, oh, maybe Tracy Community Connection Center has also been interacting with this person and they've provided some behavioral health support. So maybe we should contact them to work together to try to support this person. So you get a lot more information and connectivity to other resources and other agencies when you're using this system, especially because, as the next point says, this links homeless people to housing through the coordinated entry system. Coordinated entry is part of the HMIS that it helps connect people who are homeless, so people we're doing outreach to, people who are in shelters, and it connects them to a countywide wait list for permanent housing projects. Family resource centers in charge of matchmaking between those people and the permanent housing projects. So like when a permanent housing project has an opening, you can pull from coordinated entry a referral, the next person on that wait list. I'm not sure if the transitional rent and the flex pool is going to have to pull from coordinated entry, but it wouldn't surprise me. So if it does require participating in coordinated entry, you need to participate in the HMIS because in our community, coordinated entry is through the HMIS. The HMIS also has the potential to provide you with real-time inventory for your shelter, for your housing projects, whatever it is. So it's a really great management tool just on an agency level, in addition to a community requirement for the transitional rent assistance. Next, please. So I've just listed some of the benefits here. It's really comprehensive, good data standards. It's flexible. We can design a lot of custom services for people who want to enter more data than what they're required. We've got a lot of CalAIM providers using the HMIS to gather the information they need to do their billing. Whether they're tracking tenancy sustainment services, deposits, housing location services. We've set up a lot of local agencies to do that. So beyond tracking for transitional rent, this is a really useful way that you could consolidate your data gathering for your homeless support projects. We do admit there are some challenges, however. We know that data entry is often unfunded. It can take away time from actually serving people. Um, and some of the activities are again not funded and we have to do them. But overall, we find this is a really, really useful tool. So I try to think of it as, yeah, you might be required to do this, but it's only going to improve your ability to serve folks and to track the data you need to. And I'm ready for the next slide. One last, basically how to get onboarded. Like you contact me. Those 3 emails are in the chat. And there are just some things here that you should be prepared to do is, identify what program you want to track, identify any services you want to track. We'll need to know the funding source, grant number, and the amount of any grants. That's a state AB 977 requirement. And provide an inventory of units for any housing that you're preparing to provide. So, like, you're prepared to provide housing for 10 households at a time, one household at a time, 100, whatever it is, you'll need to be able to share some of these things so we can set you up properly. Other than that, on the next slide, you'll see that there are some fees associated with these licenses. For small agencies, these are the fees. Most of our agencies are large agencies on the next slide that have a budget of more than $1 million annually. In general, there's a new agency setup fee and a new user setup fee. We pay for the first 2 licenses for every organization. But if you have more than 2 licenses, once a year you get billed $550 for each license. Those are direct costs that come from BitFocus, the vendor of the HMIS. None of that funding goes to us. So that's a real, sorry if I talk too much, but that's as brief an overview as I could give. And I can stick around a few more minutes for questions if people have them.
Thanks so much, John. Really appreciate you and Carrie joining us today to do more of a deeper dive into these more systems that folks, may have heard about a little bit, but haven't actually accessed themselves, to get a little more comfortable with understanding what the expectations are and whether or not it's relevant for their organization, and what it may kind of start to look like when they access those systems. John, just a quick question for you. If folks are going to be operating in Stanislaus County in addition to San Joaquin, can they reach out to you and you'd be able to provide a contact for Stanislaus as well, or what would you recommend for that?
So I could, I don't know who the HMIS lead is in Stanislaus County, so I'd resort to Google just like anybody else would, I think.
I
Eliana, do you want to
know who
comment
they
on
are.
that?
Can
Oh,
talk
Carrie
about.
knows. Great. Talk to Carrie.
All right, let's let Carrie
That
go.
may be what Eliana is getting on to say too, but yeah, and I know Nieti's helped us get connected with the HMIS and Stanislaus as well. So there's, I believe, I'd have to. Oh, I see Nieti popped on, so maybe she can share more too.
I'm sure Ileana is going to say the same. It's CSA Carlos Cervantes, and he will assist you with getting some user licenses and so forth. For those that are contracted with Health Plan San Joaquin, we do have funding there with Carlos's team to fund for some of the user licenses. So I'll get his email address momentarily and drop it. And then I know, Ileana, I thought I saw you with your hand up.
No, the great minds. I think we were all going to say the same thing. So
everyone's paying attention and ready to jump in to answer questions. I love it. Thank you guys so much. There was a question. Well, first of all, I just want to, in terms of, go back a little bit, Carrie, from your presentation, there's someone else who's reiterating that, yes, they agree that Safari is useful and Microsoft Edge are useful. Chrome is not so great when it comes to PAVE. So just reiterating what you had shared there. And then a question for you, John, about whether organizations can use different HMIS platforms other than Clarity. And maybe that also relates to the location, if you could comment.
Sure. Yeah, if you're required to enter information into the HMIS in San Joaquin County, you must use Clarity Human Services. Each community only has one HMIS. That's the software that we've selected for our community. And we currently do not have the capability to just import from other databases. It has to be used.
Okay. So be prepared, potentially, folks, if you're operating across multiple counties, that you're going to be maybe using different systems to access the local HMIS there. Nieti, thank you for sharing in the chat. Just want to call out the contact for Stanislaus County, which is great. So now you guys have both contacts for both counties. for HMIS. Carrie also provided her information in the chat, her email regarding PAVE, and made herself available for folks if you wanted to follow up at another time regarding their experience with PAVE. Yes, and that I think gets us caught up. Any other questions that folks have? I'm not seeing any hands, any chats. Give it a second here. Any other questions about PAVE or HMIS? And I'll just welcome to health plans. If you guys have any particular comments you want to make pertaining to either of these, I know you're going to give your presentations later, but if on this topic, if these two topics, if you guys wanted to chime in on anything. Go ahead, Eliana.
Yeah, no, thank you. Thank you, John, for joining and providing that update and just additional context around HMIS. I just wanted to share that on behalf of HealthNet, especially for transitional rent, we're starting off with a very small provider network. And so we have earmarked our providers. We've moved forward with contracting. As Carrie mentioned, Tracy Community Connections will be our one provider at this time in Stanislaus County. And in San Joaquin County, the flow or the workflow or just the operational process looks a little bit different because the behavioral health department will be our transitional rent provider, subcontracting some of the work to CVLIC, John's team. So it does look a little bit different. But again, we're starting small, wanting to learn. We learned a lot from the implementation of CalAIM and coming on with a big network. So now we're doing the opposite. We're starting with a small network to ensuring that we are meeting the needs of our providers. And so again, we're starting small with CVLIC and behavioral health in San Joaquin County being our only providers. And from on behalf of HealthNet, we'll have some more additional resources, trainings, workflows that we'll be able to share broadly as we approach going live, which is in 6 weeks. So more to come from our end around that.
Thank you, Eliana. It's super helpful to know where the plans are at with regard to implementing transitional rent. And we didn't say this, but I'll state it, which is that transitional rent is going live for a particular subpopulation in January. And so that would be folks with behavioral health needs. And so it does make sense that there's going to be sort of a focused approach to identifying certain providers for that network to begin. So just want to make sure folks are kind of aware of that context. And I also just want to reiterate what John said, which is, the HMIS is not just for transitional rent providers, right? There is a much broader application for that. So I would encourage you guys, providers on the call, if you're engaged in supporting individuals who are unhoused or at risk of being unhoused, and you're providing any housing related type CS services, talk to your plans that you're contracted with them about HMIS and whether it makes sense for you to get in that system if you're not already in. So I just encourage you to do that. Any other questions before we move to the next section? Awesome. Well, thank you guys so much. Really appreciate it, Carrie and John. Really great information today. Thank you guys for joining and for making yourselves available after the call as well. So thanks, guys. Appreciate it.
Happy to help.
You're welcome, Navneet. Go to the next slide and I'll turn it back to you.
Awesome. Thank you, everyone. Appreciate that discussion. So now we'll move on to our cross-sector policy and regional updates. So we'll start off with our MCP update. So I think I will first pass it to Niati from Health Plan of San Joaquin, and then we'll go through the rest.
Good afternoon, everybody. Again, my name is Niati Reddy, Director of Special Projects Operations here at Health Plan of San Joaquin. And first and foremost, thank you again for all the providers that are contracted with Health Plan of San Joaquin and supporting us on this wonderful initiative of CalAIM. As you know, we're going to be going live with transitional rent. So we're very, very busy just putting that together. But again, sharing what Ileana said, we're starting with a small cohort of providers. So again, for San Joaquin County, because it's behavioral health population of Focus 1, we're going to be focused with San Joaquin County Behavioral Health as SJ County's TR provider, and for Stanislaus County, because we serve most of the population, we will have 2 TR providers, Tracy Community Connections, and thank you, Carrie, for joining, and then Turning Point Community Programs. Also, just to kind of give a color, because I know Rebecca did a great job sharing a little bit about Medi-Cal enrollment. As you know, JI also, we're working very closely. San Joaquin County Sheriff is already live with Justice Involved. We're working closely with probation as well in San Joaquin County. We're going to, start working through data sharing initiatives, workflow review, and so forth. Stanislaus County, we do have a meeting this week to discuss their implementation efforts. And I know HMA has been a wonderful partner with Stanislaus County, specifically for Justice Involved. So I don't want to take up too much time, but if you have any questions for Health Plan of San Joaquin, I think you all know my email by now, so feel free to connect with me or go through Navneet if you have any questions. I also want to remind you we have a robust, CalAIM has been, in the works for 3 years, so really grateful for the robust network we have where, DHCS did give us kudos that we have a very strong network, and we're all aligned. So thank you again for all the great work and partnership.
Awesome. If there are any questions, I will move it along to Ileana from HealthNet for any updates.
No, thank you, Nayeti. I love going after Nayeti because I always say we're so aligned as MCPs as much as we can. Thank you for providing all those updates around Justice Involved, transitional rent, and all the work that we've been doing behind the scenes. Echoing what she mentioned around our provider network, we are in a very good place with contracting with our local providers and kind of lifting those services. I think outside of that, no other major updates outside of, transitional rent going live in, again, 6 weeks. So we're really gearing up towards that. We've been doing a lot of work with DHCS around the flex pool that's going to be implemented in San Joaquin County, learning some lessons around that, and hopefully, seeing that go live again in the next few weeks. In regards to our network, we're happy to continue to have conversations around network development. We are reviewing what we call provider information forms on a quarterly basis. So if you do submit a provider interest form or information form, do know that those are going to be reviewed on a quarterly basis. And so it may take a little bit longer than it has in the past. So just as an FYI. I did want to also mention around the PAVE discussion that we are requiring all of our providers, regardless of being a transitional rent provider or not, as a new provider, we are requiring you to enroll in PAVE. I think that just brings additional flexibility around payment methodology. So if you have any questions around that, feel free to reach out to us as well, either around the application review process or a potential new service that you want to uplift within your community or your programs. I think outside of that, you guys may know my email already. I put it again in the chat in case you don't, but feel free to reach out to me with any questions that you may have. And if no questions for me, I hope everyone has a great holiday week next week. And thank you, Navneet and the Health Begins team for organizing this and always allowing that opportunity to provide updates.
Of course, thank you, Ileana. And now I'll pass it to Kat if there were any updates or things you all wanted to share on KP side.
Well, thank you so much, Navneet. I just want to thank all the providers who presented today. When it comes to KP, I really don't have any updates to provide today. And I just want to wish everyone a happy holiday and be safe.
Thank you. Just wanted to pause if there were any questions from folks that they had for the MCPs, since we do have a few minutes to address them. Otherwise, you all can always reach out via email as well. Carrie, I see your hand up, so you.
Yeah, I was just curious what Kaiser is planning to do in terms of transitional rent. Are you planning to handle that in-house, or are you contracting with CBOs?
Carrie, that's a very good question. Yes, we are actually working internally to put the processes together. And definitely when we come to a decision, we're going to definitely let the community know Kaiser process on the transitional rent.
Okay, thank you.
You're welcome.
Okay, I don't think there were any other questions, so I can move us along to some CalAIM related resources and announcements. So the first one that we wanted to just uplift was the certification opportunity for medical respite programs. That's available through the National Institute of Medical Respite Care. They have opened applications for their next round for programs to apply to by demonstrating compliance with national standards for high quality care. They did pilot this program in 2023 and 2024, and they have certified approximately, I believe, 15 to 16 facilities across the country, including 4 in California. So encourage providers that are offering respite to take a look at this opportunity. I believe they also have a few additional resources and support available. And then wanted to share some updates around the TA marketplace. I know earlier in the summer we had shared that there were quite a few changes that were being rolled out with the TA marketplace just due to the significant interest and demand as well as budgetary constraints. So I know we had shared that earlier in the summer. Some of those changes included only one project per TA recipient unless certain criteria was met, just to ensure that through the end of the TA marketplace, resources would be distributed fairly and used wisely. So within those updates that do have impacts on just the timelines for when projects are reviewed, approved, and prioritized. So they have reflected these updates in the policy guides that they released last month. So there is an updated TA Marketplace recipient policy guide that was shared last month, as well as one for vendors. So just flagging that for folks that are actively on the marketplace or looking to potentially sign on. And if you do have questions, please feel free to direct them to the TA Marketplace email. They are also hosting a webinar just for folks that are interested in learning more about the TA Marketplace. This is open to anyone that is approved to be a TA recipient, vendors, as well as organizations that are looking to learn more about the TA Marketplace. It will take place on Thursday, December 11th from 9 a.m. to 10 a.m. And they'll share some more information just around the limitations for recipients and vendors and some of the general information that they typically share in these webinars around how to submit for successful projects, any key policy updates and reminders, as well as important project timelines to keep in mind, considering that next year we'll be moving towards kind of sunsetting the TA marketplace, and then they will have some time for Q&A as well. And then also wanted to share some new CalAIM resources that are now available on the PATH On Demand resource library. This is part of the TA Marketplace, but you don't have to be a recipient or have a registered through the TA Marketplace to access these resources, as they're available to anyone that is interested in taking a look at them. So the 3 resources include a CalAIM Data Exchange Framework Bootcamp, which is designed to help organizations build a more foundational understanding of the data exchange framework and the data sharing agreement, as well as policies and procedures, and how it is relevant to CalAIM with use cases. I know we had done a dedicated office hour on the data exchange framework, so just building off of this is another resource that organizations can check out. There's also a resource on integrative approaches to prenatal mental health care, as well as a strategic partnership and communications toolkit, which was created to support efforts in building effective cross-sector partnerships, establishing effective referral pathways, and engaging with the community and implementing strategic communications. So just wanted to uplift these resources. If you click on the link in the deck, you'll be able to click through the website and download these resources, as well as existing resources that we've shared in the past. And lastly, there is another webinar that we just wanted to call out for folks, since I know there's quite a few bit of interest around community health workers and learning more about the community health worker benefit, there is a webinar happening tomorrow at 12 p.m. that's going to be hosted by DHCS and CHCF. And they'll be talking a little bit more about the community health worker benefit and how it can help improve health outcomes for diverse communities and populations of focus. And they'll also demonstrate how current policies are implemented collaboratively with DHCS, the CHW supervising providers, MCPs, as well as the CHW Bromothora workforce for system and client patient level impact. So just a reminder about that webinar. If you're interested, we have the link to register in the deck. So that was a lot of updates. So wanted to kind of move us to kind of the next steps, just to share more information around our December session, which will be the last session for the year. That will take place on Monday, December 15th. And this is part of the reoccurring Zoom link. So if you've already registered, you should have that link. And during that session, we'll spend some time kind of recapping on just work done this year and successes, as well as what you can kind of expect next year, as next year will kind of be the final year of the of PATH CPI and this collaborative. And as always, if you have questions or need opportunities to kind of talk with us a bit more, you're always welcome to email me and we can set up a separate time to chat. I know we're going to move to office hours, but I believe we're a little early since we were going to move to that at 12:30. So we do have about 10 minutes if folks had any questions that they had, or if they want to share any spotlights, resources, announcements, or successes. And then we can kind of move at 2:30 to office hours. Quiet group. Well, we'll be on. So if not, I think, oh, I see Ileana, you have your hand raised.
Yeah, for the sake of having available time, I also wanted to touch a little bit more, or just to share with this team. I think that when we think about CalAIM, sometimes we think about community supports and enhanced care management, but there's a lot of other pieces that, as managed care plans, we're also touching as we support the population health management initiative as well. And so one of those, I just wanted to share that the managed care plans are actively working with the local health jurisdictions or our public health departments on the implementation of the CHIP, the Community Health Improvement Plan. And for both San Joaquin and Stanislaus, they've been published. So I'm going to put them in the chat just for your leisure whenever you have a chance to take a look at the reports. There's a lot of great information that was informed by the community health assessment for both counties. And as MCPs, we're working again closely with the local health departments on ensuring that we're supporting with the activities that have been identified, as well as those priority areas for each county. So I'll put those in the chat. And if you have any questions, there are work groups that are happening where we're working towards identifying what those priorities are, the activities, and how do we support moving that work forward.
Thanks, Ileana. I see, John, you unmuted. No.
No, I'm waiting for Ileana to send that. I want to read that. That sounds like some great information in regards to both our counties. So I
Yeah.
definitely want to get
Yep,
into
I'm
that.
going to drop him in the chat right now. Yeah, and a lot of great information, again, that was really informed by the community health assessment in San Joaquin County as a community health needs assessment. It's derived a little bit different on how the information is captured, but I'll share that. And again, if there's any questions or if you are interested in joining any of the work groups, please let us know.
So, anything else from anyone else? on the call while we wait to get started on office hours. We're just waiting on our presenter to come through. So, Carrie.
Well, you're probably sick of hearing from me, but I figured while we have time, I just wanted to share. Last week, I went down to LA and participated in a Medi-Cal provider conference. And it was a convening of it was about 150 ECM and CSS providers. And then there was about, I don't know, there was a handful of MCPs represented, not any from our counties that I saw, but and then also some flexible operators. Anyways, it was a really interesting experience. It was really great to be around so many other providers and be able to share, like, hey, this is how we're doing this, how are you doing this, and sort of meeting up with other people. So anyways, just reporting that there is some statewide initiatives to, have these conversations. Supposedly they were going to be sharing some of the feedback from the conference up with DHCS in terms of, best practices and challenges that CBOs, MCPs, and flexible operators are facing. And anyways, it was just a really interesting and useful conference. So
Thanks, Carrie. Always appreciate you sharing, and it's always welcome.
yeah, if you get sick of me, just let me know.
So,
Carrie,
okay.
from that, did you get any insights of like not necessarily in comparison, but anything that you heard from other counties that like we could consider, or any sort of like feedback from those, from what you heard?
Yeah, so they're going to be compiling. We did a couple of different work group things throughout the day, and they're going to be compiling them all into like a recommendation document.
Mhm.
So I'd be happy to share that when I get
Yeah.
it. Yeah, because there was a lot of discussion around staff training and how we can be better trauma informed with our clients and how we can simplify and streamline the processes. I'd say that a lot of people were talking about data. So this is really
Mhm.
important, this conversation about HMIS. They're talking about streamlining data and reporting between MCPs and CBOs. So that, yeah, I'll be sure to share all of the
Yeah.
feedback when it's compiled. But yeah, it was a good experience. I'm glad I went. Um, and happy to, I'm trying to think now what I can share other than just like a lot of people are expressing a lot of frustrations. So I don't know that there was a lot of solutions coming together, but I'm hoping that maybe that document will have some guidance that is being sent up the pipeline to DHCS and maybe to some of the MCPs. So stay tuned.
Okay. I think what we can do is just take maybe a 5-minute break and then we'll reconvene at 2:30 just to allow our speaker some time to join on. So I think at this point we'll go ahead and get started with office hours. So uh, go ahead and get started there. So as I mentioned, I did send out some outreach last week, just talking about our office hours today, and how we plan to focus on financial sustainability, and assessing and managing organizational risk. So we will kind of be moving into that discussion and would love the opportunity to kind of hear from you all what questions you may have. But this will kind of serve as a primer for more in-depth discussions that we're hoping to have in December, as well as kind of going into the next year. So at this point, I'm going to pass it to Sadhna just to kind of lead us through this section.
Thanks, Navneet. And as Navneet mentioned, we do have a speaker coming in today, Dr. Josh Hyatt. And so when he joins, I'm going to turn it over to him. But I did just want to do a little bit of a framework or frame up while we wait for that, which is, so our understanding is that, across the state, really across the country, everyone is encountering new risks in this moment to their operations, to sustainability. This isn't necessarily unique to CalAIM or its implementation, but of course is also part of the ecosystem right now. And so what we were hoping to do is to start this conversation around risk and to help folks really think through different types of risk, to think through how you're assessing it, how you're managing it. And in this conversation, and I see Josh joined. Hi, Josh, how are you? I'm going to turn it over to Dr. Josh Hyatt here to talk us through, his work in this space. He is a national expert, I would say. He has joined some Health Begins national webinars to talk about a framework to assess risk. And what we're hoping to do in this session is really get your questions. What are your questions, your concerns? He's going to go through a little bit of a frame up here so that it might give some contours to the conversation, but we're really going to rely on folks in the room to, put your questions together. And as Navneet mentioned, in December, when we have our next office hours, we'll be able to, kind of answer those questions to the best of our ability, do some research and come back with folks here. So kind of with that, I'm going to turn it over to you, Josh, to walk through your slides.
Thank you. Well, good afternoon, everybody. I'm on the East Coast, so it's dark. It's like midnight outside here. So thank you for inviting me. I really appreciate it. Very quickly, I want to just kind of hit through some major points to talk about. And when we're looking at risk management, we all know there's a lot of instability in what's happening. We don't know where health policy is landing at any point in time. It seems to change on a dime. And that level of uncertainty is no good for anybody. It doesn't help healthcare. It doesn't help finances. It doesn't help individuals. So this is certainly an area where a certain level of risk mitigation, meaning looking at those things that are really complicated, that are potentially going to cost you money in the long run, and how we can maybe predict or look at how the impact of those may happen. And so we had talked a little bit about things like looking at SWOT analyses or doing something that can really help find some level ground. There's obviously the impact on healthcare. Those healthcare organizations right now, all healthcare organizations are facing all kinds of difficult backlogs around health inequities and operational risks. And so these are not really these kind of things are not a solo endeavor, and it really does kind of require that cross-functional, structured approach. So in the impact on health organizations, we're seeing a lot of violence within patients, the burnout, moral distress, and what that's causing are people to actually leave the healthcare industry, making staffing a lot more complicated, which is certainly a threat out there. And people, I've had people tell me, why would I do work that could potentially get me beaten up and is hard, and I could make the same amount working at Target, right? And it's impacting healthcare in a lot of ways around staffing because of all of these changes. And then looking at these, we can start to structure some of these questions and approaches in what's called an enterprise risk management model. And so what enterprise risk does is ERM, is that it looks at identification of risks, finding out what are those particular things that are the most problematic. So often what we'll do is we'll stratigate them and stratify where they are, as in high probability, high impact versus low probability, low impact, and kind of everywhere in between, and what that impact can be. So the higher impact things are the things that we often will focus a lot more on, because those are the ones that will drive change in organizational structures, issues within structures. Then there's assessments, which is where we start talking about, well, where are our gaps? Where are things that we are doing right now in our present state that could be done better? And so that would, drive through what are the practices that are happening? What are the structures? Are things making sense? Do they flow properly? If you're reporting events, is there a way of closing the loop on those? If there's workplace violence, how are those how is that being monitored? What kind of systems are in place? So these assessments really help build out then what your mitigation strategies are. So those are things that you do to kind of reduce those risks over time, and often involve a more systemic kind of cultured approach. And then ongoing monitoring of those to make sure that those things continue to get better over time. We'll go on to the next slide, please. And so with enterprise risk, really what we're hoping to do as leaders is navigate these challenges with integrity, kind of safeguarding institutional viability and public trust. And so when we look at risk really goes beyond just dealing with a crisis after crisis. That's what we think about. And then compliance. It really thinks about how does my organization work normally that will keep us out of trouble, and in turn and kind of ensure that long-term resilience to change. And so, we're in an era where change threatens to overshadow everything that we do. That includes compassion, and as leaders in healthcare, it's our role to kind of step forward, not just to react, but then to also lead in those moments. So the question isn't whether we're going to face challenges, but how do we choose to navigate those challenges? And so one key strategy is aligning risk management with a value-based advocacy. So we could look at things like ensuring adaptability while you're upholding whatever your mission statement, your vision, whatever your ethical commitments are to your community. And so leadership and those opportunities is really about protecting your institution, but it's also about protecting your patients and your staff. And in order to do this, it has to be really collaborative. And so no department can tackle challenges alone, and very rarely can individual organizations really tackle large systemic issues like we have with instability in our healthcare systems, and the fact that we have clinics that are closing down and things like that in rural communities. So we kind of engage our frontline staff, we start working with real ethical dilemmas, and then we start connecting together as people. And so since not all risks can really be managed at that hospital or clinic level, that's why partnering with local organizations is really important to close some of those gaps where federal and state policies start falling short. And we don't know that until we get there. And if we can predict that, if we can start do some planning and say, hey, let's just pre-think this. We know that this is probably coming down the pike. Maybe we should do something right now proactively, connect with somebody, find a local organization that can help us build resilience within our programming and also reduce systemic risks around the work that we're doing. And so then we also want to look at data, and data is a huge part of how we strive to change and become better as organizations. And so we use that data, either we share that or we use our internal benchmarking to really kind of understand where those risks lie and what we're doing to consistently avoid drift from going back or moving forward and using that as a storyline. I always said the best story that you can tell is from your data. That's the stuff that you can show where you actually had significant impact. Next slide, please. And so there are some key questions that, and I hope that you have this as a takeaway, this slide, because there's a lot of questions on here that can help you think through some of the stuff that we're looking at and how we integrate social determinants of health, political determinants of health into our enterprise frameworks, and how do we identify those emerging threats? And where do we find collaboration within ourselves, within our organizations, as collectives, within the local communities? And then how do we proactively support our patients, especially those that are in vulnerable or marginalized populations? So there's got to be really kind of that core element in there in the risk management question. And this kind of starts with embedding social determinants of health into your routine care. But identification is really not enough. We have to ensure that patient safety initiatives explicitly address disparities and discrimination risks. So how we rebuild trust and how we leverage our community partners to close these access gaps is really important. So as Sadina mentioned, what our hope is, right, is that we can come back in December and address some of your very specific risk management type questions, so that we can really kind of move forward and maybe even developing some ideas as a collective on how to preserve the good work that everybody is doing here. So I wanted to go ahead and just leave it there and open it up for conversations, questions.
Thanks, Josh. And this is Sadhana. What I was going to add here is, I know that as I was giving Josh some background for this CPI, that, folks are sitting in different types of organizations, right? Like there are folks from payer organizations, from social care provider, healthcare provider, all different sizes in the room. And so we really invite you to like come in with your first draft questions. We know it's going to, your question might not be the question that every organization represented in this room has, but it'll just really help us kind of spur that conversation. And then also want to kind of underscore what Josh said at the end here, which is, there's risks that each organization is facing. And then also there are risks that the region is facing together, right? So are there risks that the collaborative together wants to identify and has questions about how there could be mitigation strategies by coming together in the way that you have been coming together over the last few years, that might be opportunities to move forward. So just wanted to offer those two additional points. One is know that folks are coming in from different organizations in this room, and so welcome any first draft thinking on questions when someone talks to you about risk. What are the top things on your mind, including like, I don't even know where to start. And then the second part about, how is this landing with you as an organization and also as an organization that's part of this collaborative.
These are really hard questions. So and these are these are hard opportunities to kind of take advantage of as well, because it, it you may not know where even to start, where that first step looks like. And so that's something that as a collective maybe we can talk through, and just start off kind of really high level, get that big picture out of the way and kind of move forward from there.
And there's also like the possibility that this isn't resonating, right? Like we kind of queued this up to have a deeper conversation in December. And so want to make sure that folks think this is where you want to spend your time too, is like considering risk in this way. So really any kind of feedback here will be supportive for us as we're thinking through programming as well.
Think maybe it would be helpful if like folks don't want to share anything in the chat or unmute, if you can give us a thumbs up or thumbs down if this is of interest. I think okay, I think Jessica's question might be something for the MCP, so we can address that. I see Natalie dropped a question in the chat. Not sure this is inspiring. Maybe offer a poll or survey to ask about the caregiver case manager's temperature of burnout or how it's going for them.
Yeah. I'm wondering if Natalie, you don't mind coming off mute?
Hi,
Mhm.
Natalie Souza with J&M Home Care. Yeah, big kind of a broad area to think about. Some of these service delivery barriers, the burnout and the risks. We provide caregiving, home care services, respite, personal care, homemaker, and then also enhanced care management services. And there's obviously, the case managers have their caseloads, and this is a lot of, we're serving a complex population. And just really, we have so many meetings, right? We're meeting all the time. We do have quick touches, we have one-on-ones, and we usually have agendas, but I'm wondering if maybe almost doing like an anonymous poll or survey to the team and just seeing how they're feeling about where they land with the temperature of their job, and if they're feeling burnout but maybe they don't want to say anything. And we have pretty good relationships with our team. I like to think, I think everyone feels that way, but of course people might be more shy on the different meetings. But I think if it's anonymous, maybe kind of just running a little poll through an email, because I do worry about burnout. I mean, this is not an easy job. Any of the providers, we're out there in the trenches, serving, mostly underserved folks, and it's not easy. It's taxing emotionally. A lot of us have big hearts, and we carry some of this home with us. So that's my inspiration and takeaway from this right now, I think, is just tapping into my folks and seeing if we can do it anonymous. Maybe we'll get more.
I think that's a really great idea. It's a good place to start, especially considering the burnout issues within healthcare. I'm curious, does your organization do a culture of safety surveys, like annually or every other year?
We do the ECM surveys. For home care, I'm not sure there's a real formal. We do have like an admin touch where we follow up after 6 months and kind of check in with the client. But maybe we need to develop something more structured.
Yeah. So some organizations, they do what are called culture safety surveys, and I'm not sure if that one is one of the. I'm not sure what that one
It's
is.
not ringing a bell. So I mean, we do like
Okay.
different cultural trainings, but I just want to type this. I'm sorry. What was it called? The cultural.
It's called a culture of safety survey. Healthcare organizations do that, and what they do is they track things like burnout, satisfaction, psychological safety, to report concerns, things along those lines. They're generally pretty comprehensive, and those kind of surveys will get to some of that data. What often happens, though, with those surveys or any survey is that you do them, right, and then you don't. Then nothing happens with the results, and then people go, well, then why did I fill out the survey and go through all of this?
Yeah.
So I think it's a really great idea if you don't do like standard culture of safety surveys. Doing touch point surveys are really great, but making sure that you have those touch points back, so that people they see the data, and no matter how good, bad, or ugly that data is, transparency is really important, and then finding out solutions and bringing your workforce together to work through those problems and let them be part of the solution really has a huge impact on your overall culture of safety, where people in organizations that have a high touch point around culture of safety often will stay there longer, because they're more satisfied with their positions. So, and your idea about doing anonymous is a really good idea, because anonymous surveys give people the ability to feel psychologically safe to actually be honest in their reporting. But how you set it up is going to be tricky, because you're going to have to prove to them that it really is anonymous.
Yeah.
That there is no way to track back. And there are mechanisms by which to do that, but most people don't trust them. So you got to let them know it really is anonymous.
Yeah. I was looking up actually not that long ago on how to run some polls through Microsoft. That's the platform we use. And how to make it anonymous. And but I'm wondering, and we have different surveys, and we do a safety training on the care managers. Obviously, they're going into different neighborhoods and stuff. We want people to be, kind of go through that safety training. But this culture of safety survey, is there like a generic template that maybe you could share with us just so we can pull from it? Or, obviously, good old Google and Chat GPT to pull something together. But if there's a website or a platform I should be leaning into?
So I think the IHI, the Institutes for Healthcare Improvement, they have one.
Okay.
Let me look for that.
That'd be great.
I think it's the IHI. One of them has one that a lot of people utilize. It can get a little, like, it can be pretty long. I think there's ways you can edit it down but let me check on that. I think it's the IHI that has that.
Yeah, and I think one thing I would add, kind of like in the spirit of like getting ideas through this office hours. So one is, yeah, let's go see if we can find any tools that could be supportive right now. But also what I'm hearing from you, Natalie, is that, and this kind of popped out for me from Josh's slides as well, the point on like how are frontline staff voices being included in the decision making. So the piece about like, are they burning out? And then to Josh's point about how are then, if we are finding something actionable in the data from the survey, how are we then taking it and doing something with it? And so this might be, something for us to dig into. For the next session.
Love it.
Yeah, absolutely.
Yeah, we've just been kind of approaching the 1 year mark with a lot of our team members that have kind of jumped on the CalAIM train here. And, I think we're getting to that point where everyone's kind of like, wow, okay, we're moving and grooving. And, there's a lot of moving parts. So this is a great takeaway. I think we definitely want to
Can I close this?
consider. Yes, please. Thank you.
Where's my little action figures, Mama?
Sorry about that. I had to go on mute for a second.
No worries.
Yeah, any tools, and we want people to stay. We want people to be healthy and happy, and obviously that will roll out into supporting their clients and the members we serve in the communities. So it's a ripple effect. So, but I think this is great because I've been kind of worrying, and we've been talking about stuff. But like I said, I think anonymous is where I'm going to go. So thank you for the support in this conversation.
Thank you.
I saw John come off mute. John, I'm not sure if you wanted to add something here.
No, I really loved how Josh broke it down, and I'm one to agree that collaboration is key when you're looking at sustainability and looking for future. There's other organizations out there that are in the same boat, and it's better to work together than watch other people fall off. So that's the mindset I have, and I think I have that mindset here, and I think a lot of people do in San Joaquin and Stanislaus County is that they want to come together to be able to withstand the challenges that we are facing right now during this time. We know that this is only temporary, but we would hate to lose other organizations that are doing impactful work in the community, and so it's better to work together than watch people fall off.
Thank you for sharing that.
That's great. Thanks, John. And I think kind of along that same vein of being proactive and making sure people don't fall off, I know that in conversations that we've had with folks in this space and in this group, there is a concern about kind of the volume impacts based on policies that are happening locally, right? So that people are less likely to seek care right now because they're fearful of entering or leaving their homes or entering healthcare facilities when there may be law enforcement there or ICE there. And so I just wanted to kind of name that as a risk that I've heard in different spaces with different folks in this region, and curious if that's also like an area of interest to probe on. So if one is like, how are caregivers and case managers handling the burnout, kind of this risk of people not the people you care for not being able to come to the door. Is that a risk that feels present for folks in the room?
Yeah, I think that's Sana, you hit it right on the head. I think that's a real risk out there. A lot of people are actually changing the way they move within their community because of safety, because of their risk for their families. And I'm just going to plug Ileana. So based on this 2025, 2028 Community Health Improvement Plan, the CHIP thing, they actually have a breakdown in those hard to reach areas within Stanislaus and San Joaquin County. That might be an opportunity for organizations to go out to those hard to reach areas and say, hey, we are going to come to you instead of you coming to us. That might be another avenue for organizations to increase their capacity. That very well could be another opportunity for you to show that you're not alone, that we're out here, and most people will back organizations that are doing that type of work. So use this information. The CHIP, like I said, has a lot of great information in it that I just thought, and it coincides with what we're exactly talking about. So that I just wanted to bring that up.
Yeah, that's great. Thanks, John, for drawing light to that. And I think that connects, Josh, with your point about like having the data tell the story. So the community health improvement plan, and this might have been shared before you joined the call, Josh, by Eliana for Stanislaus and San Joaquin, and we can put it back in the chat here for folks. Um, helps kind of assess the risks and also find opportunity for there to be risk mitigation strategies related to it, like John was sharing. So that's great.
Yeah, I would imagine, having the climate that we have now, how do you help patients feel like your services are safe, that they're in a safe place? That's really hard. That's a hard one. That's not one I've even had to deal with in my professional career until now. So, I mean, safe in a lot of different ways, but this safe is just safe, like, to even be there, because of those kinds of fears. So, that's definitely a great thing to kind of think through. I know different states, and I'm sure California has put some structure around protecting patients and protecting individuals from what they would consider to be unlawful detainment. So though that might be able and I can look up some of those some of that within California to see kind of where they lie in there. But yeah, what are the things you can put in place so that patients feel safe?
That. Thanks so much, Josh. I know we're right about at time here for closing this out, but it sounds like, if we're pulling this together, please feel free to reach out to Navneet with any questions that come up for you related to this topic between now and December. For now, we heard this theme of safety for frontline folks as well as for patients. And so maybe, Josh, we can think about how to fashion the next office hours around those two themes.
Sounds great. Thank you.
Thank you so much for joining us, Josh.
Of course, my pleasure. Thank you for having me.
Awesome. Thanks, Sadhna. Thanks, Josh. And like Sadhna mentioned, if other things come up as you're kind of reflecting on this conversation, please feel free to email that to me and we'll make sure we address that for office hours next month. And just a reminder that our next session is on Monday, December 15th. So please go ahead and make sure you are able to attend. And we do have the registration link if you need it. But appreciate everyone's time and I hope you all have a great week. Thank you so much.
Thank you.
Thank you. Bye, everyone.
Thank you.
Thank you. Take care.